Good morning, everybody, and welcome to the Surgical Run Round. It's a great pleasure today to introduce my neurosurgical colleague, Jash Patel. Jash was educated at St Andrews and Manchester Medical Schools, did an MD at the Royal London, and then his neurosurgical training in the Northern Ireland and Republic of Ireland centres. Jash is a vascular neurosurgeon, and during his 40 years in the NHS, neurovascular surgery has gone from being a part of the general neurosurgical repertoire to a subspecialty activity largely driven by the ISAT trial led from Oxford, which transferred a lot of vascular work to interventional radiology. Following this, Jash was the UK's first pure subspecialist neurovascular surgery as the work became more and more specialised. He spent several periods in Oxford, first as an anatomy demonstrator, and then after an initial period as a consultant, he departed for Sheffield, where he spent 13 years before returning to Oxford 8 years ago, and for most of the time since, he has been single-handed the neurovascular surgeon for the department, obtaining a colleague only recently. His research interests focus on aneurysms, deep and brainstem cavernomas and AVMs. He was the clinical lead of the EU Neurist project on computational fluid dynamics to determine cerebral aneurysm rupture risk, which was funded with almost 17 million euros and involved 32 centres in 12 countries, including Oxford. His talk today focuses on one of the most complex neurosurgical procedures offered in only a few centres nationally and internationally, which is neurovascular bypass surgery. Welcome, Jash, and over to you.
Good morning, everyone. I'm going to talk for about 40 to 45 minutes on bypass surgery in the brain. Just wanted to show you Oxford Radcliffe Infirmary, where I started. And then left and came back. And I want to say a special thank you to a team I've developed over here, working with Hank Gill and the cardiac team, Jasmina, Rana, and Vivek. Jasmina is the senior most cardiac technician who comes to harvest the radial arteries for us, and my two anesthetic colleagues, Karina Fitzgibbon and Dan Wood. What you need to know in neurosurgery is this is the outcome: stick, chair, bed, or box. And we need to make them better in some ways, so it's very depressing. So bypasses were developed because there was a need, and there was a need because if you look at the circular Willis, and that's Thomas Willis, who was here in Oxford, it has areas where you can develop diseases such as aneurysms, and this is an aneurysm of the bifurcation of the vertebral arteries going onto the basilar, and with these complex aneurysms, and this aneurysm, such as the one on the carotid artery, which is called a blister aneurysm, it's a false aneurysm, so it's just a hole in a carotid artery. These were very difficult to treat. And also, in order to treat them, you had to get to the circular Willis, which is really in the center of this essentially circle. And so the circular Willis is divided into an anterior circulation and posterior circulation. So to get to these places, you can see to get to the various vessels, it's pretty deep anteriorly, and also posteriorly to get to the posterior circulation vertebral basilar system at the back. So it's quite a demanding job. The other thing is when you put temporary clips on patients, there's a risk that they will develop strokes. So in order to bypass this, just like with anything, circulatory arrest, so you need to try and reestablish circulation. So for instance, in plastic surgery, they have a 2-hour time for flaps. But in vascular surgery, the shorter the better, essentially. Now, you can get aneurysms in any location in the circular Willis. The red ones are in the anterior circulation, blue, and the green ones are in the posterior circulation. And here's an aneurysm. I just want to show you a 3D picture where you think you can see the part that's filling, but actually when you get in there, it's hard, it's calcified and thrombosed, and it's much of a bigger beast than you think. There were people who developed this in the 1960s, early 1960s, and Yazagil was one of them. He was a surgeon in Switzerland, and he started operating with a microscope and practicing in the lab for many years before he started operating on patients. And then there was Spetzler, with whom I did my fellowship in the USA, and Tulican, who developed laser anastomosis for bypasses, and I'll talk about those a little bit later. Here you can see a posterior circulation artery aneurysm, and you can see the aneurysm is on an artery at the beginning, and this is a fusiform aneurysm. This, at the beginning, supplies the brainstem, so it's very difficult to treat. And so you need to have grafts that you can transpose. And what we do is we use low flow transposition grafts. This one is a radial artery graft, so sometimes for high flow, we borrow the radial artery and we use that, or the vein. So for donor vessels, you can use things like the STA, a superficial temporal artery, or the occipital artery, as you can see over here. And for that's low flow. And for high flow, you can use the radial artery or saphenous vein. I and most people will probably try to use the radial artery. The problem with that is spasm. If you get spasm and you're supplying the brain, you can still have a stroke. And the places where you can essentially join the vessels to are the anterior circulation, which is internal carotid artery. You can use the STA, for instance, to bypass and trap vessels. And you can use interposition grafts like veins. In the posterior circulation, you can use it for basilar and vertebro-basilar artery aneurysms, where you can do bypasses and trap. So the posterior circulation bypass is much more difficult. So this was kind of developed over 20 years, I think 25 years now. And obviously, there's been a lot of input from various people that I've joined. And I myself have spent innumerable hours in just lock myself away to practice bypasses and even steal instruments for operations in the middle of the night and lock them back in the safe of the professor of maxillofacial surgery so that I could do operations. So there are 39 units in the UK. 3 did high flow. Not all of them do. 2 of them have retired. I've retired as well, but I've returned. So, and then there are 6 centers which do low flow bypasses. But there are some more people who kind of dabble into it, but people don't really do high flow bypasses. Now, why do we need to do high flow bypasses, and what are the indications over here? So there are 3 main indications, and I'll just summarize this over here. You essentially need to add blood supply, augment blood supply, and there's a condition called moya, where you can see the MC artery over here, but the MC artery doesn't exist over here, and you get this feathery appearance of vessels developing as the vessels close down. The moya, it's called moya disease, and mostly in Japan, and it's symmetrical. And as it closes down, you get new vessels growing called rete mirabile, which are anastomotic vessels. And if there's an imbalance, if they close up too quickly, you get strokes. If the vessels grow too quickly, you get bleeds. And in between, you get strokes. So we do bypasses, usually low flow, using the superficial temporal occipital artery to bypass. Sometimes we use muscle grafts. And then for reasons like when you got a giant aneurysm or complex aneurysms or even tumors where you can't, you have to resect it because it's surrounding a vessel, we do a bypass and then we excise these things or trap the aneurysm. So you're trying to replace the blood flow. And then there are reasons where we divert the blood flow. In other words, the blood flow isn't going in a particular direction. So like a flow diverter, we put a branch so that the blood flow goes in a different direction, and we do clever things with clips in different blood vessels so that the flow is in a reverse order, for instance. So this is a summary: flow augmentation, where you replenish flow, add blood flow like moya. Flow replacement, where you reinstate flow because you've taken out a tumor, for instance, or complex aneurysm. and flow alteration or reversal, where you might have aneurysms which you can't treat and you need to divert the blood flow so they clot. So this all started when people practice a lot nowadays as well. In my younger days, I had to develop a kit which was built. The field is narrow and deep, as I've said. Ischemic time is really important, and you need to avoid complications. So people use synthetic materials. I found chicken vessels from Tesco were the best in thighs. You can dissect them out and practice. Chicken in the thigh is quite a large vessel, depending whether you're a chicken or hen or whatever. And this is the device that I made. Small thing, I can hold it in my hand, where the perspex thing, you just put in saline. There's the artery, that's my graft. And this flange is because I do very deep bypasses, vertical bypasses, so you kind of practice with that, rotate it around, because your angle's all different. And this one's dried up by the time I finished and got a picture, but here you can see, put a vessel, and there's a millimeter scale. It gives you an idea. These are like tenor sutures. So I put about 8 round here in a millimeter vessel, so it gives you an idea. And then I kept on practicing because initially I was taking it very long, shortened my time, and I got less leaks. And as a result, we do bypasses in various places. Let's come to patients now. And we talked about the indications, and we talked about low and high flow, so we'll go for different things. We mentioned indications so you understand why we do them. The low flow, and as I mentioned, we use superficial occipital arteries. Now people even use internal maxillary. Some people even talk about using the dura mater itself with the middle meningeal artery. I've never used it, but it's possible. And then for high flow, as I mentioned, you have a radial artery or saphenous vein, and what you do is you take the external carotid circulation, and essentially you go in front of the parotid, superficial to it, you go inside the brain, and you anastomosis to the branch over there. So, and as you can imagine, the temporary click time is a worry. Going over the superficial part of the parotid with the 7th nerve is a worry. Everything is a worry. And some of these patients you heparinize, so it's oozing all the time. Difficult things really, and time's ticking. So as time has gone by, because the graft is not always long enough, some of us developed, I developed in fact part of it, which was to borrow the branches from the external carotid like facial artery, and so it gives you the extra length. And sometimes we just take the other radial artery on the bench, give it an extra length if we need to. Now, people use flow probes as well. I haven't got one, we're trying to buy one. This was by Charbel, and essentially you put this thing on an artery, tell you how much flow, because low flow is about 40 to 80 mils per minute. High flow is about 80 to 200 mils per minute. The easiest way I find is to just section the artery and let it go in a syringe, time it, and that's you got your flow. So it gives you a rough idea of if you're going to replace like with like, which graft are you going to use. And then let's just talk about laser. So this was developed in Holland by Tuliken. He's a professor of neurosurgery over there. And essentially what he did was, if you take, this is only for high flow bypasses, not for low flow bypasses. And essentially you take a radial artery graft, and what you do is you take your radial artery and you bring one end over here and you stitch it here. So initially they used to stitch it, but they've got a ring as well. And it's called ELANA because it's called excimer assisted, laser assisted non-occlusive anastomosis. So you don't get temporary clip time here at all. And then they put the superficial suture, and then the part of the laser here, they put through the blood vessel, and it's got 2 concentric rings of lasers. So one of them fires, the inner one fires, the outer one fires, and the inner one is like a hoover. It sucks that little flap, so it doesn't go into the blood vessel as an embolus. And then once you do that, you make a slit in the middle of the artery, radial artery. You pass the laser down because you've stitched it again on the other side as well there, and then you do the same. And so, but what you need to do is you still need to suture the anastomosis, so you're not really doing anything. So when I was trying to buy this, and I realized that this is actually 300,000 euros too expensive way to just make a hole, because it wasn't a welding laser. And my younger son told me at the time, because I remember he had the prospects, and he was saying, this is not a welding laser. So I thought, I'm not going to buy this. So it's gone down. The only place that had it in England was King's. They did 8 bypasses in 2 years, and they were very heavily criticized because you didn't have such heavy bypasses. And they didn't do them. They brought Tuliken in to do these bypasses. Okay, here you can see you can actually use a donor vessel, like I said, STA, occipital, internal maxillary, middle meningeal, and you can bypass it inside as well. You can do inside bypasses. In other words, you can use the middle cerebral branch anterior temporal artery, and you can bypass it to another side, bypass an aneurysm, or you can do side-to-side anastomosis with the anterior cerebral arteries, which are next to each other, or the posterior inferior cerebral arteries next to the brainstem, which are next to each other. The risk with those is if it blocks, then you block both sides of the circulation, essentially. So, but they're all doable. And then radial and saphenous I mentioned to you. And then the recipient vessels, again, they can go anywhere. And I think for the first time, I've got an ICA bypass that I've got to do. which is tricky because it's about 5 centimeters deep near the nerve for an aneurysm that's close to the midline. So, and then for when we start doing these things, anesthesia is really important. The main thing is intraoperative. I used to cool them, but I don't cool them anymore because the anesthetist used to worry because they used to worry about arrhythmias. I give them prophylactic anticonvulsants, and intraoperatively, when we put temporary clips, thiopenton, so they get burst suppression. The whole idea of burst suppression, you reduce the metabolic activity to such a rate that the cell is not firing any impulses at all, so it doesn't require any ATP, and it's only just enough so that it survives. So that gives you more temporary clip time. And then the approaches, as I've said, you can come from all the front approaches, all the back approaches. And then operative, you need a microscope, instruments, stenoethalon sutures, and a whole lot of other things. You need Doppler. We have pen Dopplers as well we can use, which are very helpful. And we have this thing called indocyanine green video angiography, where you inject a fluorescein dye, you change the microscope wavelength, and you can see an angiogram intraoperatively. But you have to bear in mind this is a surface angiogram. It's not a see-through angiogram. So you can only see what you're seeing at the top. So, but it's very good for checking anastomosis, if you clipped an aneurysm, to make sure blood's not going in the aneurysm, that sort of thing. And so here I'm just showing those slides again to remind you that entry circulation, and now it starts to make a bit more sense where you're putting your grafts and so on, and some of these things. But luckily, endovascular treatments have come in, and there are a lot of things we don't do now. But as with everything, endovascular has its own complications. So we have a new pathology that we treat now, complicated endovascular aneurysms, which are even harder because we reach them at the end where the patients are much worse. So you need a team. I used to do this on my own. Well, my first high flow bypass I started at 8 and finished at 6 in the morning the next day because I did everything myself, open the neck, open the head, resect the radial artery, all that sort of stuff. You need to practice, you need to be diligent, you need to have a workshop, go to workshops. I say management here because I couldn't get kit. I always had to go to the manager and beg, borrow, steal, all that sort of stuff. So you need to just make sure that you've got the right equipment so you're not suffering when you really need to do these things, and keep a good database of everything so that you keep relearning from any errors that you have. Pre-operatively, what do we do? CT angiogram is the main thing we do. We do a 6-vessel angiogram as well because we want to see the radial artery if we're going to use a high flow. Sometimes we use CT perfusion. I used to use Xenon CT till the machine died, where I used to work. We do an Allen's test with our Dopplers to check the length of the radials. And just to make sure you got an ulna and you got a palmar anastomosis, and make sure you've got a history of, if you're going to use veins, history of DVT, and find out if they are tolerant or intolerant to aspirin or clopidogrel, because that's what you're going to give them afterwards to make sure the anastomosis is patent. And then intra-op, well, the way to identify the STA, it's a very short segment, you can hardly feel it, and even with a Doppler, like 2 centimeters, and you think, where is it under the skin? So that picture I showed you with the vessels, on it, the 3D, we have a navigation machine, neuronavigation, which is like a GPS. And essentially, you can see it on the axial images where the vessel is. I draw it with the pointer, so I can draw the artery on the skin and then start dissecting on it to identify the whole artery. And then post-op, you can monitor with Dopplers. And so the nurses put the Doppler on the vessel and to see. But if it's a low flow, you can't really monitor it. And then we do a CT angiogram or angiogram, because sometimes we do the next stage of treatment, like occlude the aneurysm or occlude the vessel, that sort of thing. So I said a few things here. So I've got the next few slides, about 6 slides, are just a lot of legend, but it just tells you a few details about essentially what we do, donor vessels, all the little things that you need to think about. And you need to leave a cuff of tissue around your vessel if you harvest a radial artery, because otherwise it'll become ischemic because of the adventitia. It just needs some blood supply. And you need to remember the vena comitante when you resect it as well, because once you put the artery in, the vena comitante starts bleeding and can give you a clot inside the head without realizing. And we use a lot of papaverine, topical, to make sure the vessels dilate. And then we leave the vessel in situ. For instance, if you're using STA, we do the craniotomy around. and then we then go to the vessels to anastomose them after opening the dura. Give thiopental, we don't cool anymore. And sometimes I use a suture to measure the length so I know I'm going to get to the place I need to get to. In case I need to borrow another piece of artery from somewhere to join it together and give an extra length. And then once I'm ready, anesthetist is given thiopentone. We use heparinase saline, then the temporary clips goes on. You put the proximal, you put the distal, and then the clock starts ticking. And then, so you need to start doing arteriotomy. And it's a 1 millimeter vessel. It's almost see-through, like looking through glass. So some people use a little pen on it. We have a marker pen, so it shows you the lips of the ostium in order to suture it. I use a needle to open the arteriotomy, just ordinary green needle. I don't have any fancy scissors at the moment, which I'm trying to get. And then you need jeweler's forceps and some vessel dilators. And you need a curved tip needle holder because you need to see your suture as you're doing it. And then for the high flows, we used to administer heparin for radial artery and saphenous vein. But it was so messy. And then I found out plastic surgeons didn't give it. So I took a chance and didn't give it. Last 4 we've done without, and they've been okay. Then I found an American webinar in the same place where I did my fellowship. They don't use it. So I think it's the way to go. But you should have a low threshold to use it because you don't want vessels to clot off. And all the other things that you need, which I won't bore you with. And here are just instruments. You can see these are clips. And the clips go on to aneurysms. They look like this. They're small things really, size of your, about under a centimeter. And this is a picture of an intraoperative indocine in green, which is this one. It gives you an angiogram, which is this the one where you inject the dye. There's something called 560. It uses blood as a marker, and you can use that as well to see what's happening to your vessels. This is when you do the anastomosis, which I've just mentioned, and then papaverine, as I said, and then aspirin afterwards. The other thing I do is I give diltiazem, 60 milligrams TDS. And the reason I do that is I met up with a cardiac surgeon in Sheffield who's now died, and he'd done 900 radial artery grafts in the heart. And neurosurgery, you have a problem with spasm. So because there's such a problem with spasm, and people tried balloon sufflation, they dilate the artery before they implant it so it doesn't go into spasm. People put namodipine or infuse namodipine to try and see if it works. But ever since I found out this preparation that his technicians use, even he didn't know, which you put in with blood, Hartmann's and verapamil and so on, and also put in diltiazem. I've never had one case of spasm after operation. Now, if you use a vein, you need to remember to reverse it, draw a line so that because it's a floppy structure, the moment you pass it in and blood flows, it might be twisted in it. So you need to untwist it. And the solution I mentioned. And you need to plan everywhere. So if you haven't got one arm, you need to think about the other arm and that sort of thing. The neck, you also need to prepare. Open the neck, the 3 vessels, common, internal, external. So common, we would find all the vessels and the branches. Usually occipital, facial, lingual are very helpful because you can pull them up. You need to be careful because when you pull them up, if they're in the wrong direction, they get kink. And sometimes that will not allow enough blood flow. And I'll tell you about that later. And I used to put a chest drain through very cagily, superficial parotid. But Hank Gill has taught me a very simple technique of just putting a needle holder through and then pull up a glove with a sleeve. And we just put the graft in and pull it up. So there are lots of little tricks you can learn. And we do the anastomosis in the brain first before we do it in the neck because we don't want to be short of length the other way, going to the brain, or have tension on it, or that sort of thing. And if we are struggling up there, then we'll waste more time. So we want to waste more time here because the graft is done there. We can let the blood flow in there. Just some simple pictures over here. You can see the brain is kind of ready for an STMC bypass. I can't really see that picture. Yeah, control of the carotid in the internal carotid artery. And this one was my occipital pica bypass I was doing there. That's part of the cerebellum at the back, which you can't see. But I mean, it's not clear. There are lots of videos you can see on YouTube, so I thought I'd just skip the videos. And you can see your CT perfusion. You can see that there's an ischemic area over here. You do moya, give it extra blood supply, and that's what happens. So your threshold for an infarct is less because they're maximally dilated when they're moya. So any hyperperfusion, or if they have a Valsalva maneuver like crying. I had a child who I looked after for nearly all my time in Sheffield, and he would cry, he'd become hemiparetic, and his parents would have to buy him toys. And then as he grew, because his retin mirabile grew, because I didn't have to bypass him, that didn't work anymore because he had enough grafts himself. So that's what happens essentially. You add that blood supply. Right, so the bypasses look like this when you do a CTA. You can see the graft coming from the neck and going through the hole, and you need to make a big opening in the skull as well, just to make sure that it doesn't get nipped in the muscle or under the bone or whatever. And then you can see the graft coming in over here and joining the vessel, the MCA branch over here. So so these are kind of my results. I did this morning actually. So this is what I've done. I've done 43 low flow bypasses, and I've done 20 high flow bypasses now. So that's quite a lot actually. I hold the record at the moment, and I'm not going for records, but it's just what I've done over the years. But I've done it for various things, and it's not a happy story, because these are the sort of problems you can get. So I had one intraoperative death for a basilar artery aneurysm. I've now done five of those, of which one died intraoperatively. And the reason was each one is coiled and treated several times, but this one had come in, it was large, and my colleagues, my interventional colleagues said, they can't treat this because, and you're best operating on it. So as I tried to do a bypass, what happened was you take the tamponade off because the aneurysm is so big. You've taken the pressure off, so the transmitted pressure, which is keeping it in, suddenly ruptured. So that's how I got that death. I've had one stroke from a thrombosed graft. It totally thrombosed on me, which was very disappointing. And then I had to revise three grafts here. Actually revised two, but three of them. One was a lady with a middle cerebral artery aneurysm who became hemiplegic afterwards, densely. But her scans were fine. There wasn't an infarct. So we had a look at her, and what we found was there was stenosed, our proximal graft was stenosed. When we opened it up, the next day she was instantly moving her right side completely, opposite side completely, and within like 2 weeks she went home normal. So hypoperfusion is a problem. You need to think about these things. One of them was a revision because I'd done a dysplastic aneurysm which went really deep down into the brain, posterior temporal lobe, in the fissure, and I took out the giant aneurysm, but there's still the dysplastic segment, and I thought, I can't get this segment, this is too far away. And 9 months later, that segment turned into a giant aneurysm, so I was forced to do another bypass, and we did another bypass on her, and went deep down to trap that. She did well, but she had a tremor afterwards. And then the third one was with severe vasospasm. So if you do a graft, and you're going to do an endovascular procedure, you need to do the angio next day, and think about the procedure soon after. Because if you go later, 3-4 days later, it will occlude because there's no demand for it. It will preferentially use its own circular Willis. And so it was heartbreaking that this thing, so we took the patient to theater. 14 hours we spent on her. We did embolectomy, we did all sorts of things. And we got the graft working. There was a spastic segment of 3 centimeters, we just cut it and joined it together with enough of a graft. And actually she did very well. Afterwards we embolized her aneurysm. And then one stroke, I had a lenticular striate and anterocoroidal embolic infarct. And you can't help that with the middle cerebral arteries. Sometimes we get lenticular striate vessels. And one was an ischemic stroke. He recovered to power of 4 over 5. And then the low flow sort of things I've had. The main thing is this skin necrosis thing that I've had. Because in my younger days, I used to go for the whole vessel, thinking how much of a vessel would I need. And then you get this post-op, you see this kind of margin of gangrene, and you wonder why you got gangrene. But your plastic surgeons really help you by moving So I learned now to measure properly, and and that's kind of gone down. Okay, so just to give you an idea, it's not a happy story throughout. And then, so these are demanding operations, they're formidable cases, and you need teams. You need a lab, you need to practice, you need to be disciplined. Even now I practice. I bought a microscope and it sits in the path lab, and I go and practice there with chicken vessels, which I buy from Tesco, like I said. And you need this team. Now, I've done 2 cases where I stopped the heart as well, because that gives you extra time to operate, like 45 minutes to an hour. My low flow anastomosis will take me about 20 to 30 minutes. My high flow anastomosis used to take me 1 hour, 10 minutes. It still takes me about 50 minutes. But what I've discovered was actually you don't get strokes. You just need to stay calm, get the graft on, get it working. That's all you need to do. And I learned that from all the new thrombectomies that were coming within 3 hours. I was thinking, how come you can revive these people within 3 hours or longer? So part of the reason was, stay calm and do these things. And then, so I went to a world meeting. It was in Iran at the time, 2016, I think it was. And I presented all my watch-ups, essentially. And I told them, I know it takes everybody 20, 30 minutes, but it takes me 1 hour, 10 minutes. And the old guys started standing up saying, we do that as well. And so you suddenly find out the truth, right? So everybody has the same problem, essentially. Okay, so now I want to just show you this case, and then we'll stop here. This is a lady with a basilar artery aneurysm who came to see me a long time ago, 2007. Now, by which time I'd sent the previous 4 cases, I'd sent 1 to Leeds, 2 to Bristol, and 1 to Oxford, and they all died with endovascular treatment, okay? And she said, what do you want to do? And I said, there is an operation, it's in textbooks, but I haven't done it before. So that's the giant aneurysm. That's the basilar artery aneurysm, posterior cerebral arteries, and you can see the superior cerebral arteries there. And that's the lateral picture of the same. So my colleagues coiled it, and then she came with sudden onset headache. At the time, initially, it was 15 millimeters. And then she was a smoker. And then after coiling, this is what happened a year or so later. So you can see it's just recanalizing. And then, so she had further treatment with more coils. And then you can see part of the neck over here with the branches coming over here. So there's still a segment of the aneurysm still there, which is, and then after they put in more coils, it continued to expand. Then she got obstructive hydrocephalus because the aqueduct was blocked. That's the artifact from the, then I put a shunt in her. And then she had mass effect on the brainstem, so you can see the midbrain there completely squashed. You can see that's the aneurysm, and you can see the midbrain is almost replaced by the aneurysm, essentially. Then they get this edema. Once they start to get the edema, it's very difficult to redeem them. So these are all the options, and I'd gone to the British Neurovascular group, or my younger colleague Zed. I was at the exams writing questions, and everybody said, do everything, but do what I did, which was to do a bypass and do a Hunterian ligation, essentially. So for that, what I did was I let them put a few more coils. I put an external radial artery graft onto the posterior cerebral artery, and then I put a clip on the basilar artery. So blood flow up to here comes from the vertebrals, but from here it reverses the flow. So there's flow reversal I was telling you about, the third type of treatment, and then it starts to thrombose. So she didn't wake up for 21 days. All her scans were fine, and they were saying to me, pull out, my colleagues. But I didn't. And she woke up 21 days later, completely normal. And the aneurysm thrombosed, because it shrinks. As it shrinks, pressure is taken off the midbrain, and patients start to surface. So that's something I learned. So just to give you an idea, and you can just about see the artifact from the clip over here, and you can see the graft going all the way to the PCA. So just to give you an idea about these cases are difficult, but you can manage them, and you can salvage certain people. So thank you very much.